All right. Hey, future Canadian physicians. Welcome to another deep dive.
You know it.
If you're feeling even a little overwhelmed by the MCCQE,
Oh, yeah.
trust me, you're not alone.
Nope.
It's a beast of an exam.
It is.
But we're here to help you tackle it with confidence.
That's right.
I'm Harvey, and I've spent years on the other side of this exam as an MCCQE reviewer.
And I'm Donna, and just like Harvey, I've seen what works and what doesn't on the MCCQE.
Yeah, and we're here to deep dive into the material using trusted sources like stat pearls to help you connect the dots and really understand what matters most for this exam.
Absolutely. And a super quick disclaimer before we get started.
Yeah.
This is for educational purposes only and is not medical advice.
Right.
Always consult a qualified healthcare provider for any health concerns. Cool. Let's dive in.
So to start, remember, the MCCQE is all about testing your ability to apply your knowledge to real-life clinical scenarios.
Right.
It's not just about memorizing facts, but understanding how to use that knowledge to make sound clinical judgments.
That's what we're looking for.
Exactly. That's why we're not going to just throw definitions at you.
No.
We'll break down key concepts, explore potential exam questions, and give you the tools to think critically and approach those tricky clinical vignettes with confidence.
Yes. And for our first deep dive, we're tackling a topic that's both high yield for the MCCQE and super relevant in clinical practice. Venous thromboembolism, or VTE.
Okay, VTE, it's something you'll see throughout your medical career, but here's a fact that might surprise you.
Okay.
Did you know that VTE is the third most common cardiovascular cause of death after heart attacks and strokes?
That is true, and that's why it's so crucial to have a solid understanding of this condition, both for the exam and for your future patients.
It is. So let's break down VTE. What exactly are we dealing with here?
Well, VTE is an umbrella term that encompasses two closely related conditions: deep vein thrombosis, which is DVT, and pulmonary embolism, or PE.
Right.
And they often go hand in hand.
So imagine this.
Okay.
You're on the MCCQE and they hit you with a vignette. A patient presents with swelling and pain in their calf.
Uh-huh.
You immediately start thinking DVT, right?
Right.
And that's where the virtual triad comes in.
Yes.
This is a fundamental concept for understanding the pathogenesis of DVT, and it's a classic MCCQE favorite.
It is.
Okay, let's remind ourselves, what are the three elements of this triad again?
The virtual triad describes the three main factors that contribute to clot formation:
Okay.
hypercoagulability, venous stasis, and endothelial injury.
So hypercoagulability, I always think of it as the blood getting sticky, more prone to clotting. This could be due to inherited conditions, medications, even things like pregnancy or recent surgery.
Yeah, exactly. And then there's venous stasis. Think of it as blood flow slowing down,
Okay.
like on that long-haul flight to your elective, or even being bedridden for a few days after surgery. And then finally, endothelial injury,
Yes.
which is damage to the lining of the blood vessels.
Okay.
Trauma surgery, even something as simple as an IV line can trigger this.
Okay, so they might give you a vignette with a patient who has had recent surgery, is immobile, and has a family history of clotting disorders.
See how they're setting you up to think VTE.
Totally.
Yeah.
And knowing the virtual triad helps you put those pieces together and make that connection.
That's right.
Now, we talked about DVT.
Uh-huh.
What about PE? How does that fit into the picture?
Well, a PE occurs when a piece of a DVT clot breaks off and travels to the lungs.
Oh, wow.
And this is where it becomes a real medical emergency, because that clot can lodge in a pulmonary artery, blocking blood flow to the lungs.
So that's serious.
Yeah.
If you are suspecting a PE, what clinical features are you looking for?
That's another area where the MCCQE can really test your clinical reasoning skills.
Okay.
Remember, PE often presents with non-specific symptoms like sudden shortness of breath, chest pain, particularly with deep breaths, or even a cough.
Right. And here's the thing. They might even throw in some distracting symptoms to make it harder. I
Exactly.
have to really know what to look for and what questions to ask to make the right diagnosis.
And that brings us to diagnosis.
Okay. But this is where understanding the different diagnostic tools and how they're used in VTE is key for the MCCQE.
So let's talk about those tools. First up, we have clinical prediction rules,
boy.
like the Wells score and Geneva score. These help clinicians estimate the likelihood of VTE based on a patient's risk factors and presentation.
Think of it like a first step, helping you decide who needs further investigation.
Right.
But here's a point to remember for the MCCQE, these scores aren't perfect.
Right.
They're just one piece of the puzzle.
Yeah.
You can't rely on them solely to rule in or rule out VTE.
Okay, good point. So what's next in the diagnostic workup?
Well, a commonly used test is the D-dimer.
Okay.
This blood test measures a substance released when a clot breaks down,
Uh-huh.
and it's particularly helpful as a rule-out test,
Meaning?
meaning if the D-dimer is normal and the clinical suspicion is low, VTE is pretty unlikely, but the MCCQE might try to trip you up with a scenario involving an older patient.
Okay, what do we need to remember about D-dimer in this case?
That's a great question.
It highlights the importance of understanding the limitations of each test as we get older. D-dimer levels naturally rise, making it less reliable in older patients.
Oh, okay.
The MCCQE might even give you a scenario with an older patient who has a positive D-dimer, but actually has another condition that's causing it.
So we have to be really careful about interpreting those results in context.
Yes.
So let's say we're dealing with a patient where the clinical suspicion is high or the D-dimer is positive. What's the next step? Imaging, right?
Absolutely. And here's where knowing the gold standard imaging for each condition is crucial.
Right.
For DVT, it's compression ultrasonography,
Yeah.
a non-invasive way to visualize the veins and look for clots.
Okay. And for PE, it's CT pulmonary angiography or CTPA.
Right.
This allows for a detailed view of the pulmonary arteries to identify any blockages.
Exactly.
But again, the MCCQE might throw you a curveball.
They love to do that.
They might present a scenario where CTPA isn't feasible, perhaps a pregnant patient.
Oh.
What other imaging options could you consider?
That's where your knowledge of VQ scans comes in.
Okay.
This is particularly relevant for pregnant patients, where minimizing radiation exposure is a priority. VQ scans compare ventilation and perfusion in the lungs, helping to identify areas where there might be a blockage.
So that's diagnosis.
Yes.
But once we've confirmed VTE,
Yeah?
what about treatment?
All right.
What are the key things the MCCQE might expect you to know?
Let's talk treatment for VTE. The mainstay is anticoagulation. The goal is to prevent clot growth and stop new clots from forming.
Okay, so essentially we're aiming to thin the blood and keep those clots in check.
That's right.
But what does that look like in practice? What
Yeah.
are the different options?
You're right. It's not a one-size-fits-all approach.
Right.
We have options like heparin, which can be given intravenously or as an injection, and then there are newer oral anticoagulants often preferred for long-term management.
So on the MCCQE, could they present you with a scenario where you have to choose between those options?
Absolutely.
What factors would you consider when making that decision?
They could definitely give you a patient case and ask you to justify your choice of anticoagulation.
Okay.
And that's where your understanding of patient factors, risk of bleeding, drug interactions, and even patient preferences comes into play.
It's all about applying that knowledge, isn't it?
Yeah.
Thinking critically about the specific situation. Now, let's say we're dealing with a PE. The treatment approach changes depending on the patient's stability, right?
You got it for a hemodynamically stable patient,
Okay.
meaning their blood pressure and heart rate are okay. Anticoagulation is usually sufficient.
Right.
But if they're unstable,
Yeah.
it's an urgent situation requiring more aggressive measures.
So for those unstable patients, what are those aggressive measures we're talking about? Are there certain procedures that might come up on the MCCQE?
Definitely, you'll want to be familiar with reperfusion strategies like thrombolysis,
Okay.
which involves using clot-busting drugs.
Okay.
Then there's catheter-directed therapy, mechanically breaking up the clot. And in extreme cases, surgical embolectomy,
Wow.
which involves surgically removing the clot.
It's like a whole toolkit for tackling PE depending on the severity. Now, I remember from med school, sometimes vena cava filters are used.
Oh, yeah.
Could you remind me about those?
Vena cava filters are an interesting option.
Right.
They're small devices implanted in the inferior vena cava to catch clots before they reach the lungs.
Okay.
They're typically reserved for patients who can't have anticoagulation, perhaps due to a high bleeding risk.
So those are some of the acute management strategies for VTE.
Uh-huh.
But what about the long term? What might the MCCQE ask about managing patients down the road?
Excellent point.
Yeah.
One big question is the duration of anticoagulation.
Okay.
This is a nuanced area and depends on whether the VTE was provoked,
Right.
like by surgery,
Right.
or unprovoked.
Uh.
The risk of recurrence is also crucial in deciding how long to continue treatment.
And are there any long-term complications of VTE that the MCCQE might test on?
Absolutely.
Anything we should be aware of?
One potential complication to keep in mind is chronic thromboembolic pulmonary hypertension, or CTEPH. It's a rare but serious condition that can develop after a PE,
Yeah.
leading to persistent high pressure in the pulmonary arteries.
So it's important to monitor patients for any lingering symptoms after a PE because those symptoms could be a sign of CTEPH.
Exactly. Regular follow-up is essential.
Okay.
We need to catch any potential complications early on to ensure the best outcome for the patient.
Okay. VTE. It's definitely a meaty topic with lots of potential for the MCCQE, but I think we covered the most important points.
I agree. We hit the highlights connecting those dots between basic science and clinical application.
Now, ready to shift gears.
Let's do it.
Let's move on to another high-yield area for the MCCQE, pulmonary hemorrhage.
Okay, pulmonary hemorrhage. This is a condition that can range from mild to life-threatening,
Right.
and knowing how to manage it is key for any future physician.
Yes.
It can definitely make for some challenging MCCQE questions.
So let's start with the basics. What exactly is pulmonary hemorrhage, and what are the telltale signs we need to be on the lookout for?
It's essentially bleeding that originates from the lungs, either from the pulmonary or bronchial blood vessels.
Okay.
And the most common way this bleeding manifests is hemoptysis,
Right.
which is coughing up blood.
Now, the MCCQE could present you with a case where a patient comes in coughing up blood. What's the first thing that pops into your head?
Well, anytime a patient presents with hemoptysis, it's crucial to consider the severity.
Right.
Are we talking about a small amount of blood-tinged sputum, or is it frank massive bleeding?
Yeah, because a little bit of blood-streaked phlegm is very different from someone coughing up large volumes of blood. That sounds terrifying.
It can be a true medical emergency,
Yeah.
and that's why it's so crucial to quickly assess the situation, stabilize the patient, and then delve into the potential causes.
Okay, so let's talk about those causes. Why does pulmonary hemorrhage happen in the first place?
Yeah.
What are some of the culprits the MCCQE might throw our way?
The list of potential causes is extensive,
Right.
and the MCCQE loves to test your differential diagnosis skills. Infections are high on that list, especially bronchiectasis, a condition where the airways are damaged and widened, becoming susceptible to infection and bleeding.
And we can't forget about tuberculosis or TB,
Yes.
which can cause inflammation and damage in the lungs, sometimes leading to hemorrhage.
And then, of course, we have to think about lung cancer.
Of course.
It's a major cause of hemoptysis, especially in patients with a history of smoking.
Right.
The MCCQE might present you with a smoker who comes in with hemoptysis. Always keep lung cancer on your radar in that scenario.
Okay, so infections, lung cancer.
Uh-huh.
What else should we be thinking about?
Well, there's chronic bronchitis.
Okay.
All that irritation and inflammation can really take a toll on the airways, making them more vulnerable to bleeding.
Right.
And then you have conditions like cystic fibrosis, aspergilloma, which is a fungal ball that can form in the lungs, and even pulmonary hypertension, which can put significant stress on those delicate blood vessels.
Wow, so many possibilities.
Yeah.
That's where having a systematic approach to the MCCQE really comes in handy. So we're presented with a patient who has suspected pulmonary hemorrhage. How do we figure out what's going on? What steps would you take?
It starts with a thorough history.
Okay.
We need to understand the quantity of blood they're coughing up, how long it's been happening, and any other symptoms like fever, chest pain, or shortness of breath. These details can give us valuable clues.
And past medical history is crucial.
Absolutely.
Have they had any recent infections? Do they have a history of lung disease? Are they a smoker?
All these pieces of information
Yeah.
help to paint a clearer picture.
The physical exam can provide further insights.
Yeah.
We'd be looking for signs of respiratory distress, like rapid breathing, low oxygen levels, or a racing heart.
Right.
These signs indicate the severity of the situation and can guide our next steps.
And don't forget about listening to the lungs.
Right.
We might hear crackles, wheezes, or decreased breath sounds, which can point us in the direction of the underlying cause.
It's all about connecting those dots.
You got it. So the history and physical exam provide a foundation.
Okay.
But to really nail down the diagnosis,
Yeah.
what diagnostic tests do we absolutely need to know for the MCCQE?
Okay. Time for the diagnostic toolkit.
Mhm.
I remember chest x-rays are often the first step in these cases.
Right.
They can help us identify any obvious lung abnormalities like consolidation or masses.
Exactly. But if the x-ray doesn't give us a clear answer,
Right.
a CT scan is often the next step.
Okay.
It provides a much more detailed view of the lungs, helping to pinpoint the source of bleeding.
And then there's the one that always makes me think of James Bond bronchoscopy.
Yeah.
This involves inserting a thin tube with a camera into the airways, allowing for direct visualization of the bleeding site.
It's pretty cool, right?
Yeah.
And sometimes bronchoscopy can even be used therapeutically to stop the bleeding, which is pretty incredible. Imagine being able to visualize and treat the source of bleeding all in one go.
All right, so let's say we've diagnosed pulmonary hemorrhage. Now comes the million-dollar question. How do we treat it? I bet the MCCQE loves to throw curveballs when it comes to management.
You bet they do. But before we even think about specific treatments, remember, the first priority is always stabilizing the patient especially in cases of massive bleeding.
Right.
That means securing the airway, providing oxygen if needed, and monitoring vital signs closely.
So it's all about ADC's airway breathing circulation before
Exact.
we even think about definitive treatment. Makes sense.
And if the patient is having significant trouble breathing,
Right.
they might need intubation, which means inserting a breathing tube to help them ventilate.
Okay.
It's a critical intervention in severe cases.
And what about blood thinners?
Oh, that's a good point.
If the patient is on them, wouldn't those worsen the bleeding?
You're thinking like a true clinician. If they're on blood thinners, we need to reverse those as quickly as possible to help control the bleeding. Time is of the essence in these situations.
Okay, crisis averted. Patient is stable. Vital signs are good.
Yeah.
Now, what about those definitive treatment options? What are the must-knows for the MCCQE?
Okay, so this is where it gets really interesting because the approach depends heavily on the cause and severity of the bleeding.
Right.
One technique you'll definitely want to know for the MCCQE is bronchial artery embolization.
Okay.
It's minimally invasive, but it can be a lifesaver in some cases.
Bronchial artery embolization. That sounds intense. Can you break it down for us?
Imagine this. A catheter is threaded through the arteries to the bleeding site, and then embolic agents like tiny particles are injected to block off the blood flow to that area, effectively cutting off the source of bleeding.
Wow, it's like shutting off the tap.
Right?
But what if embolization isn't an option? Or if it doesn't work, are there other things we can try?
In some cases, surgery might be necessary.
Okay.
This could involve removing the affected portion of the lung, a major procedure, but sometimes it's the only way to definitively stop the bleeding.
So it sounds like there's a whole spectrum of treatment options, from minimally invasive to more aggressive surgical interventions.
Exactly, and that's why understanding the nuances of each approach, the indications, the risks, and the benefits is so crucial for the MCCQE. They might present you with a scenario and ask you to justify your choice of treatment.
Okay. Pulmonary hemorrhage. We've tackled the acute management, but what about long-term considerations?
Good question.
What kind of questions might the MCCQE throw our way about managing these patients down the road?
One key consideration is prognosis.
Okay.
How well a patient does long-term depends largely on the underlying cause and how effectively we treat it.
Okay.
For instance, if the bleeding was due to a treatable infection, the outlook can be good.
Right.
But if it's caused by advanced lung cancer, the prognosis might be more guarded.
And even if we manage to control the acute bleeding, are there any potential long-term complications we should be aware of?
Absolutely. Think about it.
Yeah.
Even after the bleeding stops, there could be residual damage, scarring in the lungs, reduced lung function. These are all possibilities.
Right.
So close, monitoring and managing any underlying conditions are key to preventing further problems down the line.
Okay, so we've talked about managing the bleeding, thinking about prognosis.
Right.
But there's one technique I remember from med school that I think is really important for the MCCQE lung isolation.
Oh, yeah.
Can you remind me about that?
Ah, yes, lung isolation.
Yeah.
That's a crucial technique, particularly in cases of massive hemoptysis where you need to act quickly.
Right.
Imagine a patient comes in coughing up blood, struggling to breathe. It's clear they need immediate intervention.
So the first thing we do after making sure their airway is secure
Exactly.
is figure out which lung is bleeding, right?
If we can determine that from a chest x-ray or based on their symptoms,
Okay.
the goal is to position them so that the bleeding lung is dependent, meaning we want that lung lower than the other lung.
So if the right lung is bleeding, we position the patient on their right side. And if it's the left lung, they go on their left side. Simple but effective.
Exactly. This helps prevent blood from spilling into the healthy lung and allows us to focus our efforts on managing the bleeding in the affected lung. It's a basic maneuver, but it can buy us precious time.
Okay, so lung isolation, definitely a high-yield concept for the MCCQE.
Right.
But there's another concept that's often discussed in the context of pulmonary hemorrhage, and that's the use of a double-lumen endotracheal tube, or DLT.
Okay.
It seems like it would be perfect for isolating the bleeding lung, right?
You'd think so, wouldn't you? But hold on, there are actually several reasons why DLTs are not routinely recommended in these situations.
Really? Why not?
Well, first of all, placing a DLT can be tricky, especially in an emergency setting when time is of the essence.
Right.
And DLTs have a smaller lumen than a regular endotracheal tube, which can make it harder to suction out blood and clots and could even obstruct airflow.
So there are some practical limitations.
Absolutely. And then there's the risk of malpositioning the DLT,
Right.
which could lead to ventilating the wrong lung or even worse, collapsing the healthy lung.
Oh.
That would be disastrous.
Okay, so While DLTs might have their place in certain scenarios, they're not the go-to for most cases of pulmonary hemorrhage.
Right, we typically rely on techniques like lung isolation and bronchial blockers to achieve lung separation.
It's all about weighing the risks and benefits and choosing the approach that's most likely to benefit the patient.
Exactly.
I'm sensing a theme here. Critical thinking and clinical judgment.
Yeah,
That's what the MCCQE is all about.
couldn't have said it better myself.
All right,
Okay, we've covered a lot of ground with pulmonary hemorrhage, ready for our final deep dive of the day.
let's do it.
Let's talk about another condition that's closely related to both VTE and pulmonary hemorrhage, pulmonary hypertension.
Pulmonary hypertension, or PH. Now, this one I know is a favorite on the MCCQE.
You're telling me, and it's for good reason.
Yeah.
It's a serious condition, and understanding its intricacies is essential for safe and effective patient care.
So let's break it down. What exactly is pulmonary hypertension, and why is it such a big deal? Give us the need-to-know info for the MCCQE.
Simply put, it's high blood pressure in the arteries of the lungs.
Okay.
And now that might not sound too scary, but it can make it extremely difficult for the heart to pump blood effectively.
And that can lead to a whole cascade of problems, right?
Mhm.
Shortness of breath, fatigue,
Yeah,
chest pain, even heart failure. Not something you want to mess around with.
exactly. And just like with VTE and pulmonary hemorrhage, the MCCQE will want to see that you understand the causes, symptoms, and management strategies for pulmonary hypertension.
All right, so let's start with causes. What are some of the things that can lead to pulmonary hypertension in the first place? I remember from med school, there's this whole classification system based on the cause, which can get pretty complex.
You're right, it can get complex, but for the MCCQE, it's crucial to at least be familiar with the main categories.
Right.
So let's break them down.
Okay.
First, we have Group 1 pulmonary hypertension, also known as pulmonary arterial hypertension, or PAH.
Right.
This is the type that often seems to occur on its own without a clear trigger.
And I remember it being more common in women than men.
Yeah.
Any ideas why?
It's an interesting observation, isn't it? The exact cause of PAH is still a bit of a mystery, but we know it involves changes in the lining of the pulmonary arteries,
Okay.
leading to narrowing and stiffening of those vessels.
And that increased resistance to blood flow puts a strain on the right side of the heart, forcing it to work harder to pump blood through the lungs.
Exactly.
No.
Now let's move on to Group 2 pulmonary hypertension.
Yep.
This is the type caused by problems with the left side of the heart.
Okay.
Think heart failure, valvular heart disease, certain congenital heart defects. These can all lead to Group 2 PH.
Because if the left side of the heart isn't functioning properly,
Yes.
it can back up blood into the lungs, causing pressure to build up in the pulmonary arteries.
You got it. Now on to Group 3 pulmonary hypertension.
Okay.
This type is triggered by lung diseases or conditions that lead to low oxygen levels in the blood, also known as hypoxia.
So we're talking about things like COPD, interstitial lung disease, sleep apnea, even living at high altitudes.
Exactly when the lungs aren't working properly, it can damage those delicate blood vessels and lead to increased pressure in the pulmonary arteries.
Okay, so we have PAH,
Uh-huh.
left-sided heart problems,
Right.
lung diseases.
Yes.
What about group 4?
Group 4 is unique. It's caused by chronic blood clots in the lungs,
Okay.
specifically in the pulmonary arteries.
Right.
This is known as chronic thromboembolic pulmonary hypertension, or CTEPH.
Ah, CTEPH. That rings a bell. But it's important to remember CTEPH is different from a regular pulmonary embolism, which is an acute event.
Absolutely. CTEPH develops over time as those clots organize and scar, leading to persistent blockage and high pressure in the pulmonary arteries.
And finally, we have group 5,
Yeah.
which is kind of a catch-all category for everything else, right?
So your Group 5 includes PH, caused by blood disorders, metabolic disorders, connective tissue diseases, and even certain medications.
Okay, so pulmonary hypertension, it's not just one disease, it's a whole family of conditions with different underlying causes.
Exactly, and that's why understanding the different groups and their potential causes is so important for the MCCQE. They might present you with a patient case and ask you to pinpoint the most likely cause of the pulmonary hypertension.
All right, now that we've covered the causes, let's talk about how pulmonary hypertension actually presents. What are those red flags that might make us think, hold on, this could be PH?
Well, the hallmark symptom, as you might expect, is shortness of breath, especially with exertion. It makes
Yeah.
sense, right?
Right.
The heart is struggling to pump blood through those narrowed pulmonary arteries.
It makes perfect sense, but shortness of breath is pretty nonspecific.
Right.
What other clues should we be looking for?
Other common symptoms include fatigue, chest pain, dizziness, even swelling in the legs and ankles.
Okay.
And in more advanced cases, you might see fainting spells, a rapid heartbeat, or signs of heart failure.
So if you see a patient with any of those symptoms,
Yeah.
especially if they have risk factors for pulmonary hypertension,
Yeah.
it's time to put your detective hat on and consider pH as a possible diagnosis.
Absolutely. And just like with VTE and pulmonary hemorrhage, the history and physical exam are crucial for guiding the diagnostic workup.
Okay, so we're thinking about pH. What kind of questions should we be asking during the history, and what should we be focusing on during the physical exam?
We want to dig deep into their medical history, any medications they're taking, family history, and any lifestyle factors that might be contributing to their symptoms.
Okay, and during the physical exam, we'll be looking for signs of heart and lung problems.
Right, things like an abnormal heart rhythm, a heart murmur swelling in the legs, or fluid buildup in the lungs. These are all clues that can help us confirm the diagnosis.
All right, so the history and physical give us a starting point.
Yeah.
But to definitively diagnose pulmonary hypertension, we need to turn to testing, right?
Right.
What are the gold standard tests for pH?
The gold standard is right heart catheterization, or RHC.
Right.
It's an invasive procedure where a thin tube is threaded through a vein into the right side of the heart,
Yeah.
allowing us to directly measure pressure in the pulmonary arteries.
And that's how we get that definitive diagnosis.
Right.
But I imagine RHC isn't the first test we do.
You're right. Before jumping to an invasive procedure like RHC, we typically start with less invasive tests to see if pH is likely.
And one of the most useful tools in our arsenal is the echocardiogram, or echo.
Exactly.
It's non-invasive, gives us a good look at the heart, and can even give us an estimate of the pressure in the pulmonary arteries.
It's a fantastic screening tool. We also might order chest x-rays, EKGs, lung function tests, even blood tests. And depending on the suspected cause of pH, we might do even more specialized tests like sleep studies, CT scans, or even genetic testing.
Okay, so we've gone through a whole battery of tests and we've confirmed the diagnosis of pulmonary hypertension. Now the question is, how do we treat it? I'm guessing it's not as straightforward as just giving everyone the same medication.
You guessed right. The treatment approach is tailored to the individual patient and depends on the underlying cause and the severity of their condition.
So what are the overarching goals of treatment? What are we hoping to achieve?
The main goals are to improve symptoms, slow the progression of the disease, and prevent complications. And in some cases, we might even be able to reverse some of the damage that's been done.
Okay, so now let's talk about the medications used to treat pulmonary hypertension. I remember from med school that there's a whole bunch of different drugs, and it can be really hard to keep them all straight. What are the key drug classes we need to know for the MCCQE?
You're right, there are a lot of medications out there.
Yeah.
But for the MCCQE, the key is to understand the main drug classes and their mechanisms of action.
Okay.
Let's start with vasodilators, the rock stars of pulmonary hypertension treatment.
Okay.
These medications work by relaxing and widening the blood vessels in the lungs, reducing that pressure and making it easier for the heart to do its job.
Vasodilators, they make sense.
Yeah.
Less pressure, easier for the heart to pump. But there are a bunch of different types of vasodilators, right? How do we keep them all straight?
You're right, there are a few. Some of the most common ones you'll encounter include calcium channel blockers, endothelin receptor antagonists, phosphodiesterase 5 inhibitors, and prostacyclins.
Wow.
Each has its own way of working and its own set of potential side effects.
Okay, so vasodilators are a big one. What other types of medications might we use in pulmonary hypertension?
Sometimes we use diuretics to help remove excess fluid from the body.
Right.
This can reduce swelling and make it easier for the heart to pump.
And what about anticoagulants?
Yeah.
Those blood thinners we talked about earlier, they have a role in treating pulmonary hypertension?
They can, especially in patients with pH caused by blood clots like CTEP. The goal is to prevent further clotting and potentially even break down existing clots.
So we've got medications to dilate the blood vessels.
Excess fluid and prevent clots. Are there any other therapies we might consider in pulmonary hypertension?
In some cases, we might use supplemental oxygen therapy to improve blood oxygen levels. And for patients with severe pH that doesn't respond to other treatments, a lung transplant might be an option.
It is.
Lung transplantation, that's a pretty serious intervention.
Yeah, it's reserved for those with severe disease who haven't benefited from other treatments. Okay, so we've talked a lot about medical management.
Right.
But what about lifestyle modifications? Are there any things patients can do on their own to help manage their pulmonary hypertension?
Lifestyle modifications are so important for so many conditions, and I bet they play a role in pulmonary hypertension as well. what are the key things patients should be focusing on?
You're absolutely right. Lifestyle changes are a crucial part of managing pulmonary hypertension. They can help improve symptoms, reduce stress on the heart, and potentially slow the progression of the disease. And for the MCCQE, they might even ask you about specific lifestyle recommendations for a patient with PH.
Okay, so give us the lowdown. What are the most important lifestyle changes for patients with pulmonary hypertension?
The first, and I can't stress this enough, is quitting smoking. Smoking damages the blood vessels and makes pH worse. It's non-negotiable for these patients.
Right. Smoking's a big no-no. What about diet? Does that play a role?
Absolutely. A heart-healthy diet, low in sodium and saturated fat, can help reduce blood pressure and improve overall cardiovascular health. This is something we emphasize for all our patients with PH.
Okay, so no smoking, heart-healthy diet. What about exercise? I know that for some heart conditions, exercise can be risky. Is it safe for people with pulmonary hypertension?
It's a great question, and it highlights the importance of individualized care.
Right.
It's crucial for patients to talk to their doctor before starting any new exercise program, as overexertion can be dangerous.
But if cleared by their doctor, can exercise actually be helpful?
It can, regular moderate intensity exercise can actually help to strengthen the heart and improve lung function. It's all about finding the right balance and listening to your body.
So we've got smoking cessation, diet, exercise.
Yes.
Any other lifestyle modifications that might be helpful for patients with pulmonary hypertension?
Getting enough sleep is crucial, as is managing stress.
Right.
And we often advise patients to avoid triggers like high altitudes or extreme temperatures.
Okay.
These can all put extra strain on the heart and lungs.
Okay, pulmonary hypertension.
Yeah.
We've covered a lot of ground.
Yeah.
The causes, the symptoms, the diagnostic workup, and the treatment options, both medical and lifestyle related.
We have.
But before we move on, I want to make sure we touch on some of the potential complications of PH. It's a serious condition, and I know there's some things we need to be on the lookout for. What are those key complications that the MCCQE might ask about?
You're right. It's not enough to just know how to treat PH.
Right.
You also need to understand the potential complications and how to manage them.
Right.
One of the most serious complications is heart failure.
Right. Heart failure. That makes
Yeah.
sense, doesn't it?
Yeah.
The right side of the heart is constantly working overtime to pump blood through those narrowed pulmonary arteries. Eventually, you can just give out.
Exactly. And right heart failure can lead to fluid buildup in the body, shortness of breath fatigue, and even death. It's a serious complication that requires prompt recognition and aggressive management.
Okay, so right heart failure is a big one.
It is.
What else should we be watching out for?
Another potential complication is blood clots. This is especially concerning in patients with PH caused by blood clots like CTEPH.
Right.
We often use anticoagulants to help prevent these clots from forming or getting worse.
And finally, some patients with PH might develop arrhythmias or irregular heart rhythms.
Right? And these can range from harmless to life-threatening, so monitoring those heart rhythms is crucial, especially in patients with severe PH.
Okay, pulmonary hypertension. It's a complex condition with a range of potential complications. But as with many things in medicine, early diagnosis and appropriate management can make a world of difference.
Couldn't agree more.
All right, I think we've covered a lot of ground today. We've tackled 3 major pulmonary conditions.
We have.
VTE, pulmonary hemorrhage,
Yeah.
pulmonary hypertension. We've gone deep diving into the causes, symptoms, diagnosis, and treatment options, always keeping in mind how the MCCQE might test your knowledge on these topics.
Yeah, and remember, this was just a deep dive.
Right.
You'll need to do your own studying to master all the details and prepare for those tricky exam questions.
Absolutely. But we hope this episode has given you a solid foundation and some valuable insights.
I think so.
Now ready to shift gears.
Let's do it.
This time to a condition that involves those fascinating white blood cells we call eosinophils.
Okay.
Get ready to explore the world of pulmonary eosinophilia.
Pulmonary eosinophilia.
It's a condition that can be a real head-scratcher,
It can.
and knowing how to approach it is key for any aspiring physician,
Yeah,
especially when it comes to tackling those MCCQE questions.
for sure.
Okay, so let's start by defining our terms.
Yeah.
What exactly is pulmonary eosinophilia? The name gives us a hint.
It basically means we're seeing an abnormally high number of eosinophils in the lungs.
And to jog your memory, eosinophils are a type of white blood cell that plays a crucial role in the immune response, especially when it comes to fighting off parasites and allergic reactions.
That's right.
So when those eosinophils are hanging out in the lungs in large numbers,
Yeah,
it suggests that something is triggering an inflammatory response.
exactly. But here's where things get tricky.
Okay.
There are a lot of potential triggers for pulmonary eosinophilia.
And Figuring out the underlying cause can be like solving a medical mystery.
It can?
The MCCQE loves to test your ability to think through these complex cases. So let's break down some of the most common culprits they might throw your way.
Okay.
First up, we have allergic bronchopulmonary aspergillosis, or ABPA for short.
This one's a mouthful, but the concept is pretty straightforward.
Yeah, it's basically an allergic reaction to a type of fungus called aspergillus, often seen in people with asthma or cystic fibrosis.
Yeah, this fungus is everywhere, but for people with ABPA, it
Right.
triggers an immune response in the airways,
Okay.
leading to inflammation. You guessed it, an influx of eosinophils.
So picture this. You're on the MCCQE and you see a vignette about a patient with asthma who presents with worsening cough, shortness of breath, and maybe even some brown-tinged sputum.
Keep ABPA high on your differential.
Right.
Now, let's not forget about those parasitic infections.
Remember how we said eosinophils are pros at fighting parasites? Well, when those parasites invade the lungs, those eosinophils are called into action, leading to, you guessed it, pulmonary eosinophilia.
The MCCQE might try to test your knowledge of specific parasites.
Right.
So brush up on those roundworms, hookworms, and flukes.
Okay, so we've got allergies, parasites.
Right.
What else can trigger this eosinophilic party in the lungs?
Believe it or not, some medications can actually be the culprit.
This is known as drug-induced pulmonary eosinophilia, and it's definitely something you need to be aware of for the MCCQE.
They might even give you a scenario where a patient starts a new medication and then develops symptoms of pulmonary eosinophilia.
The key is to recognize that the medication could be the trigger, and that stopping the offending drug might be all that's needed to resolve the problem.
It's a classic example of how taking a thorough medication history can be crucial for cracking the case.
Okay, so we've got allergies, parasites, and medications. Are there any other causes of pulmonary eosinophilia we should have on our radar for the MCCQE?
There are a few less common but still important culprits you should be familiar with. We have a group of conditions called primary eosinophilic pneumonias.
Okay, these are rare conditions.
Yes.
But the MCCQE might still throw them at you.
They might. In these cases, the eosinophils actually attack the lung tissue itself, leading to inflammation and damage.
Oh, wow.
Some examples include acute eosinophilic pneumonia, chronic eosinophilic pneumonia, and eosinophilic granulomatosis with polyangiitis. Try saying that 3 times fast.
Right. And then there's hypereosinophilic syndrome, or HES.
Yes, this is a rare blood disorder where the body just goes overboard producing eosinophils. And those excess eosinophils can wreak havoc in various organs, including the lungs, causing all sorts of problems.
So as you can see, the list of potential causes of pulmonary eosinophilia is pretty extensive,
It is.
ranging from relatively benign conditions to some pretty serious and even life-threatening illnesses.
That's why a thorough diagnostic workup is so important,
Yeah.
especially for the MCCQE.
All right, let's shift gears and talk about how pulmonary eosinophilia actually presents. What are the typical signs and symptoms we should be looking for? What might tip us off that we're dealing with this condition?
The tricky part is that the symptoms can vary widely depending on the underlying cause and how severe the inflammation is.
So it's not always a clear-cut presentation.
Exactly. But some common symptoms you might see include cough, shortness of breath, chest pain, wheezing, and fever.
Okay, those are pretty general respiratory symptoms. Could they also have more systemic symptoms?
Absolutely. Some patients might experience fatigue, weight loss, or even night sweats.
Right, and in severe cases, they could even develop respiratory failure requiring mechanical ventilation. That's when things get really serious.
You're right. So the takeaway here is that the symptoms of pulmonary eosinophilia can mimic a lot of other respiratory conditions.
It's like a chameleon blending in with other illnesses.
Exactly. That's why it's crucial to get a detailed history and perform a thorough physical exam to narrow down the possibilities and avoid getting sidetracked.
So what are some key questions we should be asking during the history, and what should we be focusing on during the physical exam?
We want to know everything about their medical history, any medications they're taking, recent travel, and any potential exposure to allergens or parasites.
And during the physical exam, we'll be on the lookout for signs of respiratory distress, like rapid breathing, low oxygen levels, or a racing heart.
Don't forget to listen carefully to their lungs for any abnormal sounds like wheezing or crackles.
All right, so let's say we're suspicious of pulmonary eosinophilia based on the history and physical exam. What diagnostic tests are we going to order to confirm our suspicions? What are the must-knows for the MCCQE?
A chest x-ray is usually the first step. It can help us see if there are any areas of inflammation or consolidation in the lungs.
But often the chest x-ray doesn't give us the whole picture.
You're right, it might show some abnormalities, but it's often not enough to give us a definitive diagnosis of pulmonary eosinophilia.
So what's the next step in our diagnostic journey?
Often we'll order a CT scan of the chest. It gives us a much more detailed view of the lungs and can help us identify more subtle abnormalities that we might have missed on the chest X-ray.
Okay, and then of course there's the gold standard for diagnosing pulmonary eosinophilia, bronchoscopy.
Bronchoscopy, our old friend, it allows us to directly visualize the airways and take samples of lung tissue and fluid to examine under a microscope.
And what are we looking for in those samples?
The key finding is an increased number of eosinophils. That's our smoking gun.
Right, and we might also do a biopsy of the lung tissue to look for other signs of inflammation or damage.
Now, the MCCQE might also test your knowledge of other diagnostic tests that can be helpful in evaluating pulmonary eosinophilia.
So what else should we have in our diagnostic toolbox?
We might order a blood test to check the eosinophil count. A high count in the blood can support the diagnosis, but it's not always present.
Okay, and what about allergy testing? Could that be helpful in some cases?
Absolutely. Especially if we suspect an allergic trigger, allergy testing can help us identify the culprit and guide our treatment approach.
Okay, we've made the diagnosis of pulmonary eosinophilia. Now the question is, how do we treat it? What are the key therapeutic strategies we need to know for the MCCQE?
As with most conditions, the treatment approach for pulmonary eosinophilia depends on the underlying cause.
Right, so it's all about identifying the root of the problem and tailoring our treatment accordingly.
Exactly. If the eosinophilia is caused by a medication, the first step is to stop that medication and see if the problem resolves.
Okay, makes sense. What if it's due to a parasitic infection?
Then we'll target the infection with antiparasitic medications.
And if it's an allergic reaction, we'll try to identify and avoid the allergen, and we might prescribe antihistamines or corticosteroids to help reduce the inflammation.
Now, for those primary eosinophilic pneumonias and HES, the mainstay of treatment is usually corticosteroids.
Corticosteroids, those powerful anti-inflammatory drugs, they can be real lifesavers, but they also come with potential side effects, right?
Exactly. It's all about balancing the benefits and risks.
Yeah.
We always try to use the lowest effective dose for the shortest amount of time to minimize the risk of side effects.
Okay, and in some cases, we might even consider other immunosuppressant medications to help control the eosinophilic inflammation.
Now, the MCCQE might throw you a curveball and present a patient with severe pulmonary eosinophilia that just doesn't respond to any of these treatments.
What do we do in those difficult cases?
In those rare instances, lung transplantation might be the only option.
Wow, that's pretty intense. It highlights the seriousness of this condition.
It does okay. We've covered a lot of ground on pulmonary eosinophilia, from the causes and symptoms to diagnosis and treatment. Any final words of wisdom for our listeners as they prepare for the MCCQE?
I'd say this. When it comes to pulmonary eosinophilia, keep an open mind. Don't get fixated on one particular cause.
Think broadly, consider all the possibilities, and use all the tools at your disposal, the history, the physical exam, and those key diagnostic tests to piece together the puzzle.
Right. It's like being a medical detective gathering clues and using your knowledge to crack the case.
Exactly. And remember, the MCCQE isn't just about memorizing facts. It's about demonstrating your clinical reasoning skills, your ability to think critically, and apply your knowledge to real-life patient scenarios.
Well, folks, that wraps up another deep dive into the world of the MCCQE. We hope you found this helpful.
We did.
And remember, this is just one piece of the puzzle. Make sure you study hard, stay focused, and most importantly, believe in yourself. You've got this.
You too.
And as always, this deep dive is for educational purposes only and is not medical advice. Always consult with a qualified healthcare professional for any health concerns.